Hi everyone, it's Amanda here. Thank you so much for supporting Beyond 5 and the Cancer Council. So without further ado, let's get started. So for a little bit of background, this is a presentation that I gave during a lunchtime lecture yesterday to commemorate World Head and Neck Cancer Day, which was on Monday. The title of this presentation is called The Attention to Examination for Prevention Occasion. And in this talk, I will be sharing some of the tips that I've picked up over the years on how to improve your patient intraoral and extraoral examination. We will be selling soup this afternoon at 12 o'clock at the Oral Health Centre of Western Australia. This is an event that's organised by the student associations. So if you are available, I would encourage you to come down and purchase some soup. And all of the money obviously goes to support Beyond 5, which is the face of head and neck cancer. All right, so the extraoral examination actually starts in the waiting room or even before. Many of us actually do bring our patients into the dental clinic ourselves, and whether we're doing it consciously or unconsciously, when we first lay eyes on our patient, or even before that, when the receptionist appoints them on the phone or speaks to them on the phone, we're already forming our impression of them. And there are actually things that we can pick up that will give us an idea and complete the picture as to who our patient really is. So some of the things that you may notice is their gait. Now, that may be useful to know for very practical reasons. For example, the patient may be using a walking stick and you may have to give them some assistance. They may be in a wheelchair, which will be relevant for you to know as to whether they can self-transfer to the dental chair or not. The color of their skin is very important. So I'm not talking about what race they are. Obviously, I'm talking about if they look like they're pale or they're yellow, or if they have any sort of signs of systemic disease that may be manifesting in their skin. The eyes is important. Their mood. Now, as dentists, we all know that whether the patient is anxious to begin with, or whether they've had parking troubles, or whether they have trouble finding the place, that can really impact the overall appointment. Nowadays with COVID, we don't really shake hands with patients as much anymore, but if we do go back to doing that, or if you are a handshaker, looking at the patient's hands can give you indications as to their overall health. Communication is an obvious one as to whether the patient, for example, if English is their first language, if they are going to have difficulties communicating, that will be relevant for you to know in case you do need to get an interpreter. So let's do a little quiz. Now, this quiz won't be interactive because obviously it's not a live presentation anymore, but we can talk through it. So this patient is Mr. X. He is your next patient. You meet him in the waiting room and you guide him to your clinic. And when you are reviewing the medical history, both the written form and then speaking to him about it, he denies any significant medical history. Now, what might you be concerned about given his appearance? His skin, his eyes, pancreatic cancer, altered drug metabolism, increased risk, all of the above, or none of the above? The answer is actually D, all of the above. If the patient is jaundiced, you need to be considering their bleeding risk, how they process medications, and maybe if there is a malignancy. This is another photograph of a patient's hands. Now, this is actually called clubbing, where you look at their fingers. What might you be concerned in a patient who is clubbing of the fingers? Lung cancer, heart disorders including endocarditis, lymphoma, all of the above and more, too many to name. The answer is D, all of the above and more, too many to name. So paying attention to the patient's overall appearance, even before they sit in your dental chair, can give you a really good indication if there are any health issues that you may need to discuss further with them, even if they do not declare it on the medical history. All right, so now let's move on to the extraoral examination. Now, what I sometimes see people do when they're conducting an extra oral examination is that as soon as they finish talking to the patient, they put the chair back straight away and do the extra oral examination when the patient is lying supine. Now, I think it's actually a lot easier to start the extra oral examination with the patient upright in the chair. That way you can actually palpate the structures of the neck and the TMJ a lot easier and better. General principles for doing an examination is that you have to do both inspection. So you need to visually see if there's anything different. And then you need to get your hands in there. You need to palpate it and feel if these structures, for example, if they're mobile, if they're firm, if they're symmetrical. The other point that I would like to emphasize is that as dentists, we are very used to contorting our body around the patients. Um, the patient can actually move. So for example, when you're doing an extra oral examination and you're not sure if you can actually feel the lymph nodes or not, get the patient to turn their head away and you can feel these structures a lot better. Now, we should visually inspect the patient's skin and face and symmetry. These are a couple of things that we can see in patients. For example, they may have a malar rash, which may lead you to think about lupus. Now, being in Australia, I can't tell you how many skin cancers that we pick up on the patient's face and skin. So pay particular attention to sun exposed areas like the ears. Just yesterday, I picked up a SCC on a patient's face and she saw a dermatologist to get that treated. She had another suspicious looking lesion on the ear. So particularly in the types of patients that we see, we need to be very vigilant about this because it is just so common. This is an interesting case of mine where the patient had a condition that's called hereditary hemorrhagic telangiectasia. And you can see he actually has these little blood spots, little pinpricks all over his skin, his fingers, and intraorally as well. Now, this was significant because the patient had really severe epistaxis, really severe nosebleeds for years, and this was something that he had declared in the medical history. All right, so when we are looking at the neck, we divide the neck up broadly into triangles and levels. And if you look at the photograph of myself there on the left, you can see the anterior and the posterior triangles of the neck. If you're listening to this presentation, you can actually try to palpate these structures on yourself so you can get quite familiar with them. So the big one that borders the difference between the anterior and the posterior is the sternocleidomastoid muscle. So if you turn your head away and you feel that big muscle bulging that's running diagonally down your neck, that's your sternocleidomastoid. The trapezius is a muscle that I would suspect many of us are quite familiar with. If you shrug and you pinch that muscle there at the back around your shoulder, that's something that can get quite sore at the end of a hard day's work. So that's your trapezius muscle, and that's the sternocleidomastoid. Now, the anterior posterior of the triangle, the anterior triangle of the neck is bound by the sternocleidomastoid, the midline of the neck, and the mandible. Posterior triangle is the sternocleidomastoid again, the trapezius, and the clavicle. Now let's think about the levels of the neck. The levels of the neck, I think, is something that is good to know because if you, for example, if you are communicating with medical professionals or you have a patient that's needing treatment in the neck areas, or if they're having imaging, references can be made sometimes to the different levels of the neck. And I have it pictured here in the photograph. Levels 1 to 6. Yep, so there is another diagram of the anterior and posterior triangles of the neck. There's also the submandibular and submental triangle, which is in that region. All right, so let's start off the extraoral examination first by asking for permission. Now, something that some dentists can be uncomfortable with is if they are examining a member, for example, of the opposite sex. I think that it is nothing to be too scared about. We are doing a thorough head and neck examination. So I think as long as you explain to the patient what you're doing and ask for permission. So Mr. X, I'm going to do a head and neck examination now that will require me to feel some structures in your neck. Is that okay? I think that that is sufficient, and I think that that's perfectly legitimate. So the second step after asking for permission is to identify the landmarks of the neck, which we have talked about. Now, how I do it is that I start off by examining the neck for any visible masses. If there are any visible masses, I palpate them to see what they feel like. A useful thing that I do is that I like to see if it actually moves with swallowing or not, because I think that that can give us some clues as to what we may be looking at. If it moves with swallowing, we may be thinking about the thyroid gland itself or a thyroglossal duct cyst. Now, the thyroglossal duct cyst will actually elevate if the patient lifts their tongue. If it doesn't move with swallowing, we may be thinking about a lipoma or a sebaceous cyst or lymph node or other. In the image there on the right-hand side where you can see my patient showing his neck swelling, that was actually a long-standing lipoma. Now, after visually inspecting and palpating any neck masses, if visible, if present, we also obviously look for previous scars. Now, we can palpate the thyroid and the larynx as well. Now, the thyroid cartilage is quite easy to detect in males. It's basically the Adam's apple. So what you want to do is, and if it helps, you can get the patient to actually tip their head back, and you want to find the most prominent area there. That's the thyroid cartilage. Slightly inferior to that will be the isthmus of the thyroid. And what you can do is gently palpate the thyroid on both sides. You can try to push the sternocleidomastoid muscle out of the way to actually palpate the thyroid for any nodules or swellings or asymmetry. The other thing that I like to do is very gently grasp the trachea, and you can actually see if you can move it from side to side. Now, you will feel some normal cartilaginous grating as you try to do that, and that's normal. Now, what we're looking for when we're looking at the mobility of the trachea is to actually see if we get symmetrical movements both sides, because obviously it may be asymmetrical if there are encroachment of neck neoplasms. Lymph node examination, it's very important, first of all, to refresh your knowledge of where the lymph nodes actually are. So I've got the useful diagram there on the left. And once you know where the lymph nodes are, it is important then to think about what you are actually looking for, like what is a worrying sign or what is something that you may not like to see in your patients. So these will include things like firmness or fixation to palpation, where it's not mobile. Lymph nodes in health should be soft and movable. We also want to check if the lymph nodes are enlarged, especially if they're unilaterally enlarged. Tenderness to palpation is something that I would note. However, it is not specific. Tenderness to palpation of the lymph nodes can happen for a variety of reasons. Now, the lymph nodes that we should palpate include the submandibular, the submental, the preauricular lymph nodes, the cervical lymph nodes, and the occipital lymph nodes. So the way that I do this is I use a rolling motion of my index fingers. It is important that you are palpating with enough pressure as well. So this should be about one kilo of pressure. If you do it too softly, you're actually not going to feel the lymph nodes very well. Now, with the rolling motions of the index finger, I try to keep it consistent. And as I move my fingers along the structures, I try to keep my fingers fairly close together so I don't actually miss any spots. Now, if you're doing the submandibular and the submental lymph nodes, I find it quite useful to get my fingers under there and sort of use a scooping or rolling motion to pull the lymph nodes against the border of the mandible. That way, sometimes you can actually feel the lymph nodes move with your fingers, and then they catch against the border of the mandible, so you can feel like that structure, and then as you let go, it actually moves back into place. I do palpate around the clavicle as well, although that can be a little bit more difficult to do without causing some tenderness. So back to my point about palpating with enough pressure, it should not be overly comfortable for the patient. You don't want to be hurting the patient, but if you're using enough pressure for your lymph node examination, your patient should definitely feel it. A tip for examining the occipital lymph nodes: if the patient is lying back and they have their head resting against the seat rest, I actually find it quite useful to get them to lift their head slightly. That way you can feel those lymph nodes a lot better. All right, so this, I've already spoken about this. So you can get the patient to lift and turn their head away to assist you with this. A kilogram of pressure, pulling it softly against the inferior border of the mandible, rolling motion of the fingertips, and making sure you don't miss any areas. I like to do this one side at a time rather than doing both at the same time. Now, we talked about lymph node enlargement being one of the things that we need to consider. So, what actually is considered an enlarged lymph node? When you're feeling the structures of the neck, what is a size of a lymph node that will cause you to think, that's a little bit larger than I would like? So, option A, less than half a centimeter. Option B, a centimeter. Option C, a centimeter and a half. And option D, larger than 2 centimeters. So the answer is larger than 2 centimeters. If you are a person that likes analogies like me, you can actually go into your fridge or your freezer and pull out 2 peas. 2 centimeters is roughly the size of 2 peas. Now, I'm not going to go through a temporomandibular joint examination in detail because I've done several presentations on this already. And if you're interested in this, you can message me and let me know, and maybe we can talk about it. But for a general examination of the temporomandibular joints, what you want to be doing is making sure that you're evaluating the muscles of mastication with adequate pressure. Extraorally, this would be between 1 kilo to 2 kilograms of pressure, and the muscles that you do want to be feeling are the masseter and the temporalis. It is not as easy to reliably palpate the medial pterygoid, and the lateral pterygoid is almost impossible to palpate with any sort of certainty. Now, the things that you want to look at for the temporomandibular joints is that you want to look and see how the patient is opening, if there's any limitation in mouth opening, if there's end feel, if the patient's mouth opening can actually open a little bit wider with a passive stretch. You want to make sure there's no swelling around the jaw joints. For joint sounds, what you want to do is put your fingers around the lateral pole of the condyle. So if you're not sure where this is, put your fingers in front of your patient's ears and get them to open and close, and you will feel the condyle move. Now, when you are assessing for joint sounds, it is not enough to get the patient just to open and close once. So what I would recommend is that you can do it 3 times and actually see if you can detect any clicking or crepitus. Now, when you're looking at the patient's mouth opening, I find it really useful to see if the patient has deviations or deflections with the jaw. Deviation means that their jaw opens to one side. A deviation means that the patient mouth moves to one side as they open and returns to midline. A deflection of mouth opening means that it opens to one side and it doesn't return to the midline with continued opening. Now, limitation in mouth opening, the way that we can assess this, the normal range for maximal mouth opening is actually quite variable, approximately 40 to 60 millimeters. 60 is probably a little bit larger, but what I will get you to do is actually you can use a measurement such as a ruler. If you don't actually have a ruler, you can use your fingers. So if you stand your fingers up vertically and use that to assess the patient's opening, 4 fingers of mouth opening is about 45 millimeters, and it's usually quite accurate. All right, so now let's move on to the intraoral examination. So the keys to the thorough examination, unsurprisingly, is looking carefully, because if you don't look, you won't find. You need to be assessing all of the oral cavity, and you will see from some of my photographs later, some of these suspicious lesions do like to play hide and seek with the clinician, so they can be in very easy to miss areas. I like to do this at the start of my examination because I have fresh eyes, and I also recommend a systematic approach. So I don't think there's any one right way to do it as long as everything is looked at. And the more times you do this, and the more times you do this in the same manner that you've done it before, it actually forms a habit, and then it becomes automatic, and then you don't miss any spots. If you have loops, put them on. Because that will really help with your intraoral examination. And lighting is really important. So if you have a headlight, if you have white light, that is the best. If you are working in a practice or you have a dental chair with yellow light, I would actually recommend trying to see if you can change the bulb to white light. If you're doing the intraoral examination and your overhead light stays in the same place, the entire time that you're doing the intraoral soft tissue examination, that's not you're probably not doing it correctly, because if you don't have a headlight, the overhead light needs to move as you move to get all of the angles and all of the little crevices in the mouth. This is just a illustration of how important it is to get adequate lighting, because if you don't, you really can't see what you're looking at. Now, if you have anything that you've picked up and you are not sure if it is anything to worry about or not, one of the tips that I like to give is to actually record the finding in detail and then bring the patient back in 2 weeks and see if it's there still. For example, if you have an area on the lateral border of the tongue and you think that the patient may have bitten themselves, maybe it's an area of frictional keratosis, look for the cause. So, for example, there may be a broken tooth or a sharp edge of a restoration. Remove the cause, so polish the tooth, and then bring the patient back in 2 weeks. If it is related to frictional keratosis, for example, if the tongue has been rubbing on the sharp edge of the tooth, that should resolve. But it's important to record these findings because when you bring your patient in 2 weeks, you won't necessarily remember what it looked like to begin with. If you have a clinical camera, taking a photograph is much easier and much more accurate. If you don't have a clinical camera, it is important to record the findings with as much detail as possible. So measurements, the shape, the texture, the borders, etc. If you have decided that the patient does require referral, now I would suggest sending the photograph with the referral. I'm not going to go through this in too much detail, but there are lesion descriptors that if you get familiar with, you may find actually helps your description a little bit more. These are universal and it helps you when you are communicating with both in your clinical notes or with a specialist. And you can pause the video at this stage if you did want to look at the images that I have there. Similar for this one. Couple more tips for my intraoral examination. I actually use 2 mirrors when I'm conducting my intraoral examination. I find it a lot easier to do that. Now, I think you should get your fingers in there and palpate structures as well, but having 2 mirrors as you first conduct the examination allows you to move around a lot easier and visualize the structures a lot better without your fingers in the way. With the 2 mirrors as well, I can stretch out tissues. So for example, here I'm showing stretching out the buccal mucosa. There is a condition that's called leukodema, which looks like milky white film on the buccal mucosa, and that disappears as you stretch it. So the mirror can really help you with that. When you are examining the tongue, I like to get the patient, first I visually inspect it, and then I get the patient to stick their tongue out and I hold on to it with a piece of gauze. That way I can actually manipulate the tongue and look all the way back as far posteriorly as possible. So I find using gauze to hold the tongue useful as well. Now, this here is some photographs of how of the areas to look for when you're doing the intraoral examination. I've put the lip vermilion there, even though I know it's not actually in the mouth. The reason for that is I don't think I can emphasize this enough, that looking at a patient's lips is so important, especially in Australia. Actinic colitis is very common. A lot of our patients have it. That is where there is generalized mucosal change of the lip vermilion, which is the area where females put, or males, or people put lipstick on. What you want to look at as well is that how the vermilion border looks like. There should be a clear demarcation between lip and skin. Now, if it looks like there is loss of vermilion border, then it's another sign of actinic colitis. When you're examining the labial mucosa, you should be palpating the lips as well, and you can actually reflect the labial sulcus so you can see all the way down into the sulcus. And I would suggest to do this both for the maxillary and the mandibular. Now, if you do feel firm swellings in the lip, it is important to get these assessed. One of the tips that one of my previous consultants actually gave me is that if you are feeling a swelling in the upper lip, that is very unlikely to be a mucocele. Mucoceles don't happen as commonly in the upper lip. That should be urgently evaluated. Now, when you're looking at the left and right buccal mucosa, I like to use the mirrors. Well, I like to visually inspect, use the mirrors, and then use my fingers. Don't forget to look into the buccal sulcus, which is actually quite a good spot to find lichen planus. Look at the retromolar areas and also the gingiva. With the hard palate, besides the visual inspection, it's important to look for asymmetry and also to actually put your fingers in there and palpate and see if there are any swellings. Making sure that you are looking at all surfaces of the tongue, the dorsal, the lateral, the ventral, including the posterior aspects, as far back as you can go. I don't do this routinely, but sometimes you may be able to visualize the base of the tongue by using the reflection of a dental mirror if you feel that there's anything there. So besides the inspection of the tongue by looking at it like that, it's also important to assess how the patient is protruding and moving their tongue. So you can get them to stick their tongue out first and then move it from side to side and see if there's any asymmetry or deficiencies in that. With the floor of the mouth, most patients will have floor of the mouth pooling with saliva, so it is important to dry that off and have a good look. Floor of the mouth and lateral tongue are high risk sites, so I always spend a little bit of time on those, making sure that they're okay. Now, with the oral pharynx, you want to have a good look too. Look at the soft palate, the uvula, the tonsils, and the tonsillar pillars. Now, after you finish all of this, you want to palpate the salivary glands as well, both the floor of the mouth and the parotid ducts, to make sure that the flow of saliva is clear and you can get, and the ducts are not blocked. This is just to re-emphasize some of the points that I made before. So palpating the lip and reflecting it to look all the way down into the sulcus, palpating the palate for any asymmetries, and checking the saliva glands at the back, at the end, to see the quality and quantity of the saliva. Some common areas that people can miss, again, reflecting all the way, looking down into the sulcus and around the frena, lateral tongue, floor of mouth, uvula, and soft palate and oral pharynx, looking as far back as you possibly can, and then also checking the lips and assessing for actinic colitis. So this is a patient of mine that I saw. He had unilateral neck lymphadenopathy there, as you can see in the photograph. Now, if you look at his tongue, is there anything unusual that you note? There are a couple of things. One of it is that it deviates to one side as it protrudes out. The other is that the surface of the tongue is actually quite hairy and pigmented. When I asked the patient why, or when I started to investigate a little bit further, it turns out that the patient had difficulty swallowing and was not able to eat hard foods, which is why I think the tongue looks like that. And the deviation of the tongue was because he had oropharyngeal squamous cell carcinoma. Another tip, which sounds really obvious, but I have seen people do intraoral examinations without removing the denture. The dentures or any prosthesis in the mouth must be removed to look at every part of the soft tissue. This was a patient of mine who had full upper dentures, as you can see there. She is a dentulous. She had a swelling in the buccal sulcus, and this turned out to be lymphoma. So have a look at these photographs. Which do you think is squamous cell carcinoma? The squamous cell carcinoma is actually the image on the extreme right on the top. But my point with putting this photograph here is that it can be very difficult to tell them apart clinically, and really any of these could have been suspicious. The next point that I want to make is that the images on the left there are very obvious. They are not things that dentists will miss when they're doing their examination. So first of all these four photographs are squamous cell carcinoma. But just because something is not obvious doesn't mean that it should be ignored. So when we do the intraoral examinations, just because something doesn't look very obvious doesn't mean that we can ignore it. So here we can see the spectrum of squamous cell carcinomas of the tongue. The next point is not to forget to check back in 2 weeks. If you have decided there's a lesion that's worth reviewing, make sure you bring the patient back at the end of 2 weeks and have a look. Now, this was a patient that was referred in to us. Unfortunately, she was referred in but didn't present for a long time. We brought her back in 2 weeks because we needed to get arrangements in place. And during that time, you can actually see how much the squamous cell carcinoma has mutated. All right, so finally, I would like to just conclude by giving some red flags. So if your patient has any of these signs, they need urgent referral. The red flags include weight loss, voice change, difficulty swallowing, night sweats, ear pain, unilateral lymphadenopathy, and fixation and duration of the intraoral tissues or lymph nodes. Fixation means that there is loss of mobility, and induration means that there's hardness or firmness. The therapeutic guidelines, the Purple Clown book, has a very good table in there for some other red flags that I would encourage that you read. If you are a ADA member, There is an article on there on checking for oral cancer. If you do want any more references as well, you are more than welcome to contact me. That's my email address. That's my UWA email address. If not, you can always find me on Instagram at Oral Medicine Oral Pathology, or on Facebook, A Spoonful of Oral Medicine. And I'm more than happy to discuss anything in this presentation at any time, or anything oral med related at any time. All right, thank you. Bye.